Good afternoon, dear students. Our today's topic of lecture, systemic vasculitis. Systemic vasculitis is a large group of the disease that are characterized by inflammation, is followed by destruction of the walls of the small, medium, and large vessels. As a result, developing ischemia of tissues and organs. Systemic vasculitis have inherent relapsing cause by also they can often escalate. Symptoms of disease largely depend on blood vessel localization, its size, as well as the activity of the inflammatory process. And of course, they may affect different size of vessel, arteries, veins, capillaries. But about causes of inflammation, usually it's immunological hypersensitivity reaction, type 2, type 3, type 4, type 2 complement dependent, type 3 immune complex mediated, type 4 cell mediated, and maybe a direct invasion of microorganisms and toxins, and more about immune complex deposition. Deposition of immune complex leads to activation of complements, release of C5a fracture of complement. It leads for hematactic for neutrophils. Neutrophils leads to damage of endothelium and vessels, and as a result appear fibrinoid necrosis. And of course, we have histological pictures from autopsy. First, normal artery at top, and in the bottom picture, white blood cells infiltrate media and adventitia of the vasculitis artery, and we have polycells changes, inflammatory changes in the vessel. Classification of vasculitis based on Chapel-Hill nomenclature and depends of the size of vessel. And we have large vessel vasculitis like giant cell arteritis, Takayasu arteritis, medium vessel vasculitis, example of them polyarteritis nodosa, Kawasaki disease more often, and small vessel vasculitis. Antineutrophilic associated small vessel vasculitis like microscopic polyangiitis, vaginal granulomatosis, and drug-induced antineutrophil antibody associated vasculitis, immune complex small vessel vasculitis, Schönlein-Henoch-Purpura, and others we can see in this slide. Also, we have cryoglobulinic vasculitis and Sjögren syndrome vasculitis, Behçet disease, Goodpasture syndrome, serum sickness vasculitis, paraneoplastic vasculitis, vasculitis in case of inflammatory bowel disease, and others. Large vessel vasculitis usually involves aorta and its large branches, and to extremities and head and neck. Medium-sized vessels vasculitis involves arteries of the visceral organs, and small vessels vasculitis, usually due to immune complex deposition. Type 3 hypersensitivity reaction involves arterioles, venules, and capillaries. We have information in this slide and a picture about it. A good example of size we have in the level of renal artery, aorta as example. Large artery vasculitis, renal artery is medium size, and glomerulus is about small size vasculitis. Clinical manifestation of vasculitis. Clinical picture depends on size. Large vessel vasculitis may be present with loss of pulse or stroke, for example. Medium vessel vasculitis present with infarction or aneurysm. Small vessel vasculitis present with purpura. And for all vasculitis, present general features, fever, weight loss, myalgias, weakness, and others. Diagnostic of vasculitis can be difficult. It's patients from intensive care unit, maybe condition, life-threatening condition, and differential diagnostics sometimes very difficult. It's very difficult. And we should use instrumental diagnostics, laboratory testing, chest radiographs, and CT scan for lung involvement and primary and secondary vasculitis very often with pulmonary symptom maybe, and routine laboratory tests like complete blood count. We have normocytic, normochromic anemia, leukocytosis, thrombocytosis, sometimes elevated of speed sedimentation erythrocyte rate, elevated C-reactive protein. Urine analysis also should be performed in all patients, which very similar to patients with systemic vasculitis, including patients with normal renal function. Proteinuria and microscopic hematuria are commonly appear in vasculitis, in Wegener disease, in microscopic polyarteritis. Antinuclear antibody and rheumatoid factor also may be positive. And specific antibodies like DNA antibodies, NIS antibodies, anti-scleroderma 70, anti-centromere antibodies, anti-GO1 antibodies clearly favor connective tissue disease and also may be present. Lung anticoagulant and anticardiolipin antibodies may occur also in vasculitis. Antibodies to basal membrane, to lung, to the kidney, and immunoglobulin E antibodies also very often we can find in Churg-Strauss disease. And the good results we have, if possible, provide biopsy. Biopsy of skin is very good decision if present skin changes. Renal biopsy if we suspect some renal abnormalities, some type of glomerulonephritis, and video thoracoscopy with lung biopsy. It's also a very good decision if we have unknown diagnosis, unknown infiltration in lung, and suspect Wegener disease, for example. Two types of antinuclear antibodies, cytoplasmic and perinuclear, we can find. Okay, anti-neutrophilic antibodies is more common for small vessel vasculitis. Okay, treatment of vasculitis in general. Whereas the type of vasculitis and the severity may be very, the general approach to the therapy remains the same, immunosuppression therapy. And phase of induction remission, consolidation, and supportive treatment in remission. Usually, for induction, we use 3 or 6 months, and then during a long time, maybe 2 years, we should provide supportive treatment. Intravenously, injection of methylprednisolone we can use in case of very severe course of disease, up to 1 gram. It's pulse therapy, 1 or 2 3 days. Uh, and in other situation, we may use the average dosage of prednisolone, 1 milligram per kilogram per day. And we can use cyclophosphamide in very severe cause and very active process till 2 milligrams per kilogram per day, maximum dosage 150 milligrams per day. And we may provide combination therapy, cytostatic plus corticosteroids. And also, extracorporeal detoxification methods may be used, plasma exchange, and immune globulin, anti-T-cell therapy, and biological agents we can also use for treatment. Large vessel vasculitis is common vasculitis, and first of all about the private form, giant cell arteritis. Usually occur in patients more than 50 years old and is often associated with polymyalgia rheumatica. Female more than male appearance, vessel involvement, first of all, aorta and its major branches, with extracranial branches of the carotid artery, involvement of ophthalmic branch of external carotid artery, and sometimes it leads to blindness. And we have data about similar disease, Takayasu disease, and differential diagnostics between giant cell arteritis and Takayasu disease. First of all, about years of patients for giant cell arteritis, it's usually more than 50 years, approximately 70 years, and Takayasu much more younger. Giant cell arteritis, microscopy, biopsy, focal granulomatous inflammation of temporal artery, fragmented internal elastic lamina by giant cells. Clinical features in general, fever, fatigue, weight loss, temporal headache, facial pain, tender scalp, painful, palpably enlargement in tender temporal artery, generalized muscular aching and stiffness, and sometimes temporary or permanent blindness. Also, maybe lingual ischemia, maybe vertigo or hearing loss, maybe dysphagia and sinus involvement, and sometimes even psychosis or other psychiatric symptomatic. Laboratory tests more often, speed of limitation of erythrocytes is very high, and temporal biopsy reveal some inflammatory changes in infiltration of giant cells. For treatment, we use more often corticosteroids, and we have a picture of biopsy and a picture of external examination, and we have we can see temporal artery with stiffness, with giant cell infiltration. Okay, polymyalgia rheumatica seen in 50% of patients with giant cell arteritis. Muscular pain, morning stiffness of proximal muscles, elevated of speed of sedimentation of erythrocytes, without inflammatory joint or muscle disease, sometimes present low-grade fever, weight loss, malaise, and low dose of prednisolone leads to good results in this. It's also for differential diagnostics very important. Takayasu arteritis. Granulomatous inflammation of the aorta and its major branches usually occur in patients younger than 50. And in this picture, we can see vessels and different size of vessels in both parts of the body, and very severe narrowing. And of course, this patient have different number of blood pressure in the radial artery and different pulse. Polyarteritis nodosa. Polyarteritis nodosa, it's necrotizing inflammation of medium size or small arteries without glomerulonephritis or vasculitis in arterioles, capillaries, or venules. And necrotizing vasculitis of medium and small arteries, age approximately 40s, men more often than female. And very often we have general symptomatic fever, 50% weight loss, also approximately 50% of patients. Vasculitis can be variable in any patients and in some patients, and very difficult diagnostics of this condition. We have diagnostic criteria: weight loss more than 4 kilograms, livido reticularis, testicular pain, myalgias, weakness, mononeuropathy, polyneuropathy, increasing of diastolic blood pressure more than 90, increasing of creatinine level, hepatitis B also very often accompanied, and we have any abnormalities in the specific investigation when we use contrast way, and biopsy also reveal some changes of small and medium vessel. Mononephritis present in 50% of patients, renal involvement in case of 60%, more often hypertension and glomerulonephritis. And glomerulonephritis uncommon for this category of patients, and because it's medium size. Abdominal involvement in 45%, arthralgias, myalgias 64%, testicular pain approximately 25% of patients. Pulmonary involvements are very rare. It's very rare. Classically, without association with antineutrophilic antibodies. Also, in medium size, we have Kawasaki disease, arteritis involving large, medium size, and small arteries, and associated with mucocutaneous lymph node syndrome. Also include its in process coronary artery, aorta and vein may be involved also. Usually occurs in children, and usually it's about Japanese country, and diagnostic criteria: fever for 5 days, more than 5 days, plus next for criteria: bilateral conjunctival injection, mucous membrane changes, extremity changes, edema, erythema, polymorphous rash, cervical lymphadenopathy also present. We have picture of specific rash in the face in children, specific tongue like strawberry, very similar to children infection, and the rash can look like anything. This is an example of a morbidiform rash, and also like these changes maybe. Clinical manifestation: arthritis and arthralgia present in 7 to 25% of patients. Arthritis may be present, CNS involvement, gastrointestinal symptoms, abdominal pain, diarrhea, vomiting, hepatitis, cardiac involvement, coronary artery aneurysm, myocardial dysfunction. Differential diagnostics should be between viral infection, measles, adenovirus, toxic mediated illness, scarlet fever, toxic shock, rickettsia or spirochete infection, drug reaction, juvenile rheumatoid arthritis, endocarditis, and so on. Okay. And markers of systemic inflammation increase. Anemic syndrome also may be present. Still pyuria, retro origin, and we have findings in the biochemical analysis. And if we analyze synovial fluid, we have inflammation and hyponatremia. Okay, the incidence of coronary aneurysm is up to 25% in untreated patients, typically develop in the subepic phase of the illness, which is 2 to 8 weeks after onset. Okay, and treatment, we can use intravenous immunoglobulin and aspirin about 2 months. Next disease, Shendenhinoff purpura, most common systemic vasculitis in children, affecting small vessels, capillaries, venules, or arterioles, immune-mediated reaction, deposition of immunoglobulin A immune complexes, and occurs in cold time of the year. About 50% of cases are preceded by infections. Streptococcus infection is more common before vaccination. Viruses maybe as trigger. Clinical presentation. First of all, palpable purpura in absence of thrombocytopenia, arthritis or arthralgia, abdominal pain in 50% of patients, renal disease 20 to 50% of patients, and we have a picture with specific hemorrhagic rash in case of hemorrhagic vasculitis. It's petechial rash, very similar to thrombocytopenia but more bright color. Gastrointestinal symptomatic may be submucosal hemorrhage of gastrointestinal tract, maybe changes in endoscopy. Sometimes symptoms we may reveal only after operating treatment and the same treatment in abdomen like in the skin. And sometimes we have surgical complication, gastrointestinal bleeding and damage of gastrointestinal tract and renal disorders also may be later. 50% of patients with renal disorders and usually presented with glomerulonephritis. And it's about poor prognosis when we have renal involvement. Laboratory findings, immunoglobulin A levels may be elevated, platelets count should be normal, inflammatory markers may be elevated, and urine analysis with red cells, white cells, casts, proteinuria, negative rheumatic factor usually, and about Wegener granulomatosis. It's a very interesting disease with damage of respiratory tract and necrotizing vasculitis affecting small to medium sized vessels. And necrotic glomerulonephritis is very common. We have damage of upper airways, damage of kidney, damage of lower airways, bilateral pneumonitis, maybe chronic sinusitis, ulceration of nasopharynx, and renal disease also very high. 80% of patients suffer from renal disorders. Okay, and nasal symptoms, epistaxis, rhinorrhea, erosion of septal cartilage, saddle deformity, recurrent sinusitis. oral cavity, hyperplasia on gingivitis, and edema, ulceration of larynx, and ears also may be damaged. And the key for diagnostics, of course, laboratory tests with anti-neutrophilic antibodies, and sensitivity of test is very high, 65–90%. Okay, this is picture of lung with infiltration, with nodules and any cavities, and it's also about vaginal granulomatosis, damage of the lungs without infection. Treatment, we use cyclophosphamide 2 mg per kilogram plus corticosteroids 1 mg per kilogram to achieve remission. We also may use azathioprine or methotrexate instead of this treatment, and combination of many drugs if patient needs. Churg-Strauss syndrome, it's also very interesting disease associated with bronchial asthma, with eosinophilia. Duration of asthma usually more than 10 years. We can see symptoms of the disease, maybe skin changes with livido reticularis, maybe nails changes with necrosis, and we can discuss about microscopic polyarteritis. It's also about small vessels, immune deposits, and about glomerulonephritis and skin involvement. Also common features like fever, arthalgias, pulmonary involvement maybe, weight loss, and associated with specific type perinuclear anti-neutrophilic antibodies. We can see picture. Also, we have essential cryoglobulinemic vasculitis, very often association with hepatitis C infection, and also skin rash in case of essential cryoglobulinemic vasculitis. Very rare cutaneous leucoclastic angiitis and Behçet disease in our region. It's very rare. We have pictures about mucus damage in case of Behçet disease. It's end. Thank you for your attention.